So my name is Fran McNicol. I'm a consultant colorectal surgeon at the Royal Liverpool University Hospital. The 2-week rule referral pathway is designed to pick up the cancers and also to exclude cancer as rapidly as possible in the patients that don't have cancer, so that we can then focus all our attentions on the tumours we find. There's a set of symptoms which for colorectal cancer are quite vague, to be fair. So, change in bowel habit, weight loss, abdominal pain, bloating, and then anemia. Those can be symptoms of colorectal cancer, but are also very common symptoms in patients who have other benign conditions of the bowel. Because the sort of constellation of symptoms that go with the possible colorectal cancer pathway are quite vague, there is a bit of overlap often between colorectal cancer symptoms and gynecological cancer symptoms. So bloating, feeling full, a bit of loss of appetite, noticing increase in girth without bloating can be due to gas or just due to fluid sort of thing. So a really useful test to add on to the panel at the point of 2-week rule referral would be a CA125. And then if that is elevated, if it's bloating, bit of discomfort, generally off, rather than very specific GI symptoms or very specific bowel symptoms, then that would lead you to send them down the gynae pathway. The information that we request to be attached to the pro forma is a symptoms, how long they've been going on for, relevant medical history, a full abdominal exam, a digital rectal exam, and a panel of bloods, including ideally ferritin to check for anemia. CA125 is a really useful add-on to that because a lot of these symptoms in ladies could be associated with a gynecological cancer. And then the new development is that we are asking the GPs to request a FIT test as well, which is a test that does an immunotest for how much blood is hidden in the stool. And if all that information is provided, when we vet the referral, we can make very easy, rapid decisions about what that particular patient's best way through the diagnostic pathway is. The reason digital rectal is so important is because if we want to do a CT colon, the CT colon doesn't give you good pictures of the bottom end of the rectum and anus, and so someone has to have examined that patient. If the GP's done it at the point of referral, we can vet the referral and we can get a CT colon really quickly. If the GP's done it at the point of referral and found a mass that they're worried about, then that patient goes from being vaguely symptomatic to having a specific sign that is very, very suspicious, and we would then see them within a couple of days. Our hope for that is that it will stratify patients into risk so that we can pick up the group that we really do want to rush through. And then for the patients, we're trying to minimise their number of visits to hospital because it's a big deal. In terms of bowel prep, the patients have to fast for 2 days, liquid diet only. They have to drink 2 litres of fluid that will then give them profuse diarrhoea, quite often associated with a bit of vomiting because it is fairly horrible to take. And they will be, a bit hypotensive, feeling a bit weak and a bit washed out. And that's just the prep. They then have to come to hospital in that state, and then, again, lie on a colonoscopy, on a bed for a colonoscopy. So it's not, it's not only an invasive test, it's not a passive test for the patient. So again, can they transfer independently? Can they turn themselves over? Can they get to the loo without any problems? Full on respect to our primary care colleagues. I have the privilege of knowing that everyone that comes to me has been vetted and screened already, and there's a good reason why they're here. And I know that's not always the same in primary care. So it is tricky to pick out the right patients to refer, and everything that we've done with this pathway and with the recent innovations has been about picking the patients that most need our urgent attention out of the pile, and we hope that that facilitates it for the GPs. The more information, the more stuff that is correct, the more, you know, patients that have had their blood test, that have had their digital rectal examination, and that have had their fit test at the point when they come through for vetting, that means that we know exactly what to do with them and how quickly to do it. You know, we're seeking perfection, but we're also very well aware of the importance of safety netting. And if you've done everything, someone doesn't quite fit into a category, or they've been fit tested and they've been assessed as low priority, but their symptoms are changing and deteriorating, or you're not happy, you know, as the referring clinician, the GP is the person who's seen that patient, and so of course their opinion, you know, has weight, and you know, safety netting advice is really important. And if you feel people need to be expedited, then get in touch. There is definitely a referral process for the majority of practices. It should now be an online referral, and yeah, check with your practice manager and make sure you're fully up to date.